everyone. Thank you for inviting me to the CardioMust conference. It is indeed a very great pleasure to be here. And thank you for the warm hospitality that has been extended. Thank you again for the invitation. So today we'll be talking about improving outcomes in congenital heart disease and the multi-system collaboration. Congenital heart disease, as much as we'd like to think of ourselves as cardiologists, but really the heart affects every system in our body. And it's so important that we think about how specifically in congenital heart diseases, we may be able to incorporate a collaboration with all the other subspecialists. This is Lorraine Sweeney. She was the first patient with congenital heart disease to be operated at Boston Children's Hospital in 1938 at the age of 7 years. She was the first patient who underwent a patent ductus arteriosus ligation. This was when congenital heart disease the era really started off and moved on. We've moved very far from there. And now we're able to operate on little babies as neonates, very much in their infancy, and undergo complex congenital heart disease surgeries. So therefore, we have patients who are operated on at birth, who survive and have a long road of chronic congenital heart diseases. And it's a lifelong chronic condition that our babies that are born with will need to be managed for. So there are numerous collaborations that would be involved in looking after these patients as we care for them. So today we will be talking about the quality of life in adults and adolescents with congenital heart disease. We'll be talking about their neurodevelopmental evaluations. We'll talk about how the liver may be involved in some of these patients, how the kidneys might be involved, endocrine system manifestations, and what are the recommendations and evaluations that we can have for some of these patients. Quality of life, what is it? It's different for you, it's different for you, it's different for women, it's different for cardiologists, it's different for non-cardiologists. So it's very different. It's one of those domains which is very frequently interrogated, but the definitions for quality of life vary between all of us. This is one of the standard definitions that has been used for quality of life. It is the degree of overall life satisfaction that is influenced by an individual's perception of certain important life events to them, including matters that are related to health or unrelated to health. And they may be positively or negatively influenced by everything that happens along. So specifically with quality of life, there are two thoughts that come up. There's a health-related quality of life, which is related to our daily physical conditioning, which is related to what we are able to do in our day-to-day activities with regards to health. And there is another perspective which talks about the satisfaction with life, how happy one is with our lives. Are we happy? We sleep well, we are happy with what we do in our life. So what are the factors that may be associated with quality of life outcomes in adults with congenital heart disease? Education is very important, and it's been found that as an adult with congenital heart disease, education plays a role. Employment, being employed as an adult is very important because it's important that we be able to learn and earn our day-to-day wages. Marriage, very important to most of us. Disability, whether we are affected by our health in such a fashion that we may be disabled from it, contributes to our quality of life perception. And lastly, physical endurance, whether we are able to perform our day-to-day activities without being out of breath. Some of our patients are so ill that they may be out of breath by just walking from this end to the stage to the outside exit. And that is not okay. That is not okay that these patients go through, and that is really affecting their quality of life. So what is the data with regards to quality of life? In general, it has been perceived that patients poor quality of life have more consequences. In general, they believe that their health affects their day-to-day activity. They have weaker perceptions of personal control. They don't believe that they can control what happens to them day to day. They cannot plan their life because they don't know if tomorrow they'll be admitted to the hospital or tomorrow they'll be able to walk that distance that they're supposed to walk from one end of their office to another. They're less likely to believe that treatment could control their illness. They don't know if we as physicians, when we institute certain treatments, is that going to make them feel better tomorrow? Tomorrow is, am I going to be able to walk that longer distance? Am I going to be able to go through that work day properly without having any manifestations from my heart disease? So generally, this is the data from numerous 14 centers through 14 different countries that has been collected and that looked at quality of life in patients with complex congenital heart diseases, Fontan patients. And what has been seen is that physical activity scores correlated directly with quality of life. So in general, if patients were able to perform walking or participate in sports, they perceived their quality of life as being better. Patients who are more sedentary perceive their general health as being poor. Patients who perceive their general health as being excellent had higher quality of life scores. So in general, it is known also that quality of life has a direct correlation to exercise capacity and functional measures of exercise tolerance. So you would wonder, is it that you're more active, that is the reason why your quality of life is better? Or is it that your quality of life is better, you perceive yourself as better, and that's the reason why you're more active? It's the chicken and the egg, or the rooster and the sunrise phenomena. Moving on from adults to adolescents. What do adolescents or teenagers perceive their quality of life perception? Because this is the spectrum that we're going to talk about. And so I'm going to talk about in sort of reverse fashion from adults all the way through infancy. In general, with adolescents, the self-related health and physical functioning scores were noted to be lower in patients with complex congenital heart diseases as compared to mild to moderate congenital heart diseases. Patients with complex congenital heart diseases thought that they did poorly as compared to other patients. In terms of physical appearance, very important as a teenager, very important as an adult too, but as teenagers, it plays more into their lives. In general, patients who had significant forms of congenital heart disease had their Tanner stages, achieved their Tanner stages about 1.5 to 2 years after compared to normal population. 20% of participants, or in this particular study that looked at generalized outcomes in patients, adolescent patients with congenital heart disease, 20% of participants had short stature. And it is also well known that abnormal anthropometric scores are associated with lower quality of life. Menstrual disorders are known to be present in adolescents and young females with congenital heart disease. Almost 20% of them may be affected with mild to moderate disabilities, and 10% may have significant menstrual disorders. We looked at, in a large cohort of administrative database, we looked at patients with adolescents, hospitalizations with congenital heart disease, and we found that almost 30% of patients hospitalized belonged to the single ventricle group, and more than 50% were biventricular congenital heart diseases. 30% of these were ICU admissions for almost a day. Can you imagine, as a teenager, being admitted to an ICU with congenital heart disease? That is a significant toll on the mental well-being of teenagers. Almost 12% are admitted with heart failure. Of these admissions with adolescent admissions with congenital heart disease, the majority of them are admitted for electrophysiology studies and arrhythmias. 20% almost of them are admitted with these hospitalizations. Next, moving on to neurocognitive function. It is important that as an adolescent with congenital heart disease or an adolescent in general, that you be able to perform well in school, in high school, in college. And in general, when studies have looked at patients with Fontan and transposition, these are the more significant forms of congenital heart disease. Generally speaking, psychomotor function and attention has been loaded to be abnormal and impaired in patients with Fontan and transposition as compared to the milder forms of congenital heart disease. Brain volumes. This is an area of upcoming research and a lot is being done in this field. We have a registry of neurocognitive function in patients in the United States and some international centers also participating. Most of these registries are now finding that total brain volumes and intracranial volumes, including cerebellar volumes, are smaller in patients with complex congenital heart disease. And this starts off very early in the fetal life. So what are the predictors of abnormal developmental trajectories that you can find from the time that the baby is born and is in the hospital? Supplemental tube feeding. If a baby, when he or she is born, requires supplemental tube feeding with NG tube or orogastric tube feeding, those patients have been known to have cognitive disturbances later on. Language disturbances are also noted in patients with supplemental tube feeding. So also are motor impairments. In addition, looking at socioeconomic status, in general, it is believed that patients who are on public insurance or have no insurance, and this probably doesn't apply the no insurance category in Egypt, but public insurance tend to have cognitive impairments as congenital heart diseases. And most importantly, maternal education plays a role in the language development of these patients with congenital heart disease. So if the mothers have high school education or less, then those patients are more likely to have language impairment as they keep growing. Next, I'd like to talk about liver diseases in patients with congenital heart disease. There's a specific spectrum of liver diseases, which has been described as Fontan-associated liver disease. This is a complex mechanism involving perioperative liver injury, hemodynamic changes of cardiovascular function associated with the Fontan physiology, and additional factors that may be affecting liver. In general, it has been seen that liver stiffness on elastography in patients with Fontan is much increased as compared to, it's almost a double of that compared to patients with normal hearts. It has also been seen to be abnormal in patients with biventricular congenital heart disease, probably the most common being tetralogy of Fallot or pulmonary valve diseases. And these patients are known to also have impaired hepatic stiffness. So what can you do? What can you as cardiologists, what can you do as physicians to help these patients that may have liver involvement? You may avoid hepatotoxins, avoid adverse lifestyle habits. So pay attention to high fat diet, low calorie supplementation, and so on. Hepatitis B and C vaccination is of prime importance in avoiding liver disease in patients. Advocating for it as cardiologists is important. And most importantly, also, there is a role for screening. There is a risk for late hepatocellular carcinoma in many of these patients. So it is important to screen these patients on a regular basis so they may be picked up very early on. Protein losing enteropathy, which is an abnormal loss of serum proteins from the gut, is also seen very commonly in many patients with complex congenital heart disease who have been palliated with Fontans. Almost on an average, about 10% of patients may have this. They're usually asymptomatic in the early stages, but frequently have chronic diarrheas. So it's important to ask your patients about these symptoms, talk to them about these. Secondary manifestations of hypoalbuminemia are often seen on these patients. And of course, the gold standard for diagnosis is the stool alpha-1 trypsin level. People have talked about acute kidney injury in adults, and I think it's often talked about, but it's also important to recognize that almost 40% of postoperative Fontan patients and patients with complex congenital heart disease may have acute kidney injuries. These are associated with longer ICU stays, overall hospital length of stay, as well as congenital heart disease surgeries. The long-term outcomes, however, of patients with acute kidney injury as an infant is not known because a lot of these patients are not even followed for these conditions. It's also important to recognize that many of them may have associated congenital anomalies of their kidneys. So we routinely screen babies born with complex congenital heart diseases with a kidney ultrasound. Hypothyroidism has also been seen in 10% of patients, specifically with Downs and Turner syndrome. Tetralogy Fallot patients, almost 25% of them may have hypothyroidism associated with 22q11 deletion or DiGeorge syndrome. Amiodarone-associated hypo and hyperthyroidism is also very common, especially since arrhythmias are very common in this population. Vitamin D deficiency and low bone mineral density associated with fractures is also frequently seen in complex patients with congenital heart disease. Single ventricle Fontan palliations who have protein-losing enteropathy are frequently treated with steroids, which also has the associated problem of low bone mineral density and fractures. Patients with advanced heart failure and cyanosis also have this problem, and so also are patients with Downs and Turner syndrome. Thrombogenesis may be seen in up to 30% of patients with Fontan physiology associated with factor VIII deficiency and protein C deficiency. And lifelong thromboprophylaxis is recommended on this. The kind of thromboprophylaxis is up to debate, and there's a lot of research that has been ongoing, but we routinely use aspirin and not infrequently warfarin in many patients with Fontan physiologies and some forms of congenital heart diseases. So in conclusion, I hope I've given something to think about to this entire group. And I'd like to summarize that it's important to match cues to care. Exercise should be used as a diagnosis and a prescription in patients with congenital heart disease. It is important to think about neurodevelopmental evaluation of these patients, and also very important to think about their feeding, nutrition, and the gastrointestinal and renal system surveillance, because that eventually affects their outcomes and long-term outcomes, as well as an adult patient who survives and does well in their day-to-day activities. Thank you very much for your attention.
Thank you very much. It was just an amazing presentation. Thank you very much. And you had the importance of preventive cardiology, and you have stated a very nice item by saying that adverse lifestyle. So this is very good of you, and thank you very much. Pressing on exercise, how is it important? How is it, the very cheap capsule which prevent around 20 chronic disease? Thank you very much. Thank you.
Thank you.
Do we have any questions?
Thank you very much. I am honored to present one of the eminent intervention in the field of the cardiology. Thank you.